Welcome to tonight's webinar. My name is Allie Armstrong. I am a field marketing specialist for Axonics Therapy, and I will be moderating this webinar. This evening, Dr. Roberts will be speaking about bladder dysfunction, the common symptoms patients experience, and treatment options that may help you regain control. Without further ado, I would like to introduce Dr. Roberts.
Hi, everybody. Thank you so much for tuning in tonight and listening to this important talk. This is a very near and dear topic to me. There's a lot of women out there and a lot of men who have undiagnosed, untreated urinary symptoms, and I'm hoping that this reaches that population of people so that we can treat them and improve their quality of life. So just a little bit about myself while people continue to log in. It says I'm from New Zealand. Well, yes, I was born in New Zealand, but traveled back and forth between the United States and overseas for approximately 13 years, really settling in Oregon, and then eventually moving to Louisiana to pursue my master's of public health. And then I went on to LSU medical school in New Orleans, go Tigers, to complete my medical degree, after which I went on to do my surgical training at UTMB in Galveston. I still really love Galveston and go there frequently. After I graduated from residency, I did stay on and I was an associate professor of urology at UTMB for a couple of years and really enjoyed teaching residents and operating and running clinics there, and then eventually moved to the Hill Country and established a private practice that I ran for 3 years before joining Urology Austin. So I joined Urology Austin in this past December, and it's been great, and I have just really enjoyed becoming a part of their world-class urology. So let's talk a little bit about our topic tonight. There's some important safety information. Okay, so I see a lot of men and women in clinic with lower urinary tract symptoms. Sometimes they come in and say, you know, I get up 3 or 4 times a night to pee. I have this urge to pee and I can't make it to the bathroom, or I pee and then immediately after I pee, I think I've emptied my bladder and have to go again. Some people have a little more vague symptoms where they feel a pressure in the pelvic area as if they have to void all of the time and are unable to empty the contents of their bladder sufficiently. What these symptoms do is they make you miss out on some very important aspects of life. There are people who are afraid to go on road trips, travel, or go on vacations. Even something as simple as sitting through a graduation ceremony can be really intimidating because they fear that if they can't make it to the bathroom, they may pee on themselves, and then the embarrassment comes from the incontinence and perhaps the smell that they're worried other people can perceive. They're also socially constrained because they can't go places where they don't know that there's going to be a restroom. So going to the park where there might not be a public bathroom where they can, you know, play with their kids or grandkids can be very difficult. So people with incontinence issues or lower urinary tract issues will oftentimes suffer from a degree of depression. We actually find depression rates in people with incontinence are much higher than those who don't suffer from incontinence. So this is a very important topic because your ability to maintain a healthy lower urinary tract symptoms and incontinence can affect almost every aspect of your life. I want everybody to know that you are not alone when it comes to incontinence. There are many different kinds of incontinence. The one that we are going to focus on today is called overactive bladder or urinary frequency or urgency urinary incontinence. This is so common that it's estimated to affect 50 million people in the United States alone. The cost of that to people's quality of life and even their pocketbook is pretty staggering. It's a $12 billion industry. In the year 2000, people in the United States spent $12 billion on incontinence devices. For example, Depends or Poise pads. So this is this is not a small industry. My goal is to help people to spend less time thinking about their lower urinary tract and what it's cost them, and more time participating in their daily activities. One other symptom that is very rarely discussed because it can be very embarrassing is fecal incontinence. So 19 million people in the United States have difficulty controlling their bowel movements. The system that we're talking about today can help both with urinary urgency, urinary frequency, urinary urgency incontinence, as well as fecal urgency and fecal incontinence. Now, I will say I am not a GI physician or a gastroenterologist, so I like anyone who has issues with fecal incontinence to see their gastroenterologist to rule out other causes. So let's talk a little bit about the lower urinary tract. So the bladder really has two functions. You want to be able to store urine, and you need to be able to store enough urine in your bladder to give you a sufficient amount of time to do your daily activities. For example, if you have a very small capacity bladder where your bladder wants to empty its contents frequently because it doesn't want to hold very much urine, then you're going to spend a lot of your time in the bathroom, because as soon as you drink something, your bladder is going to feel the stimulation of the small amount of urine your kidneys produce, and it's going to signal you to go to the bathroom prematurely. So you want a bladder that is able to store. And what that means is to have enough capacity in that bladder so that you're not always in the bathroom constantly emptying. So capacity is important. Its ability to stretch is important. And the ability for the urethra to contract and maintain a secure outlet while you're storing is also important. Then, once it's socially acceptable, you want the ability to control your voiding and go to the bathroom in a socially acceptable place. So, for example, once you feel that urge to go to the bathroom, you need to be able to have enough time to find a place to go to the bathroom where you're not running or fearing a leak or an accident. The emptying phase is such that the urethra, which is the outlet, the tube that you pee through, has to relax, and the bladder has to contract, thereby pushing urine out of an open channel. And that's how you empty your bladder. The normal bowel function: as the rectum fills, there are stretch receptors on the rectum. Those stretch receptors are activated, and those nerve signals are sent to your brain, making you feel like it is time to empty your bowels. Now, you should have the appropriate amount of warning to get to the bathroom in order to empty your bowels in a socially acceptable way. So in order to defecate or stool or have a bowel movement, nerve signals coordinate the relaxation of your pelvic floor with the muscles of the rectum that push stool out. So it all has to work in conjunction with the proper nerves going to and from the brain and to and from the pelvic floor and the rectum. Your symptoms, such as fecal urgency, fecal incontinence, urinary urgency, frequency, or urinary incontinence, may be caused by an overactive bladder, which is a bladder that compels you to void quickly, and you may not be able to control that, leading to incontinence. You may have symptoms because you're not able to empty your bladder, whereby your bladder is not receiving the signals to contract and expel the contents of the bladder, thereby retaining the urine. And of course, fecal incontinence, where you have that involuntary loss of stool. So what is an overactive bladder? This is, by definition, it's the frequent and urgent need to empty your bladder, and often results in unintentional urine loss. So when I say urinary frequency, that is when you're peeing 8 or more times a day. When I say urinary urgency, it is that sudden urge to pee and you cannot control it. urgency incontinence or urge incontinence is the loss of urine due to the feeling that you need to pee urgently. One of the things that people describe to me as patients when they come in to talk about their incontinence is certain triggers. For example, I have patients who say the urge occurs when I'm in the kitchen washing dishes, or I've just gotten home and I put the key in my door and I turn that key and then I got to run to the bathroom or else I'm going to, pee all over the sidewalk standing at my door. Other triggers can be running water. And then, some people don't have any triggers. They'll just be walking, get an urge. They can't identify that trigger, and then they'll have an incontinence episode or a leakage episode. Some people say they have this urge to void both during the day and at night where they're getting up frequently. And I want to point out that sleep deprivation from getting up frequently at night is very real, because if you can't complete a sleep cycle, you're never going to get that restorative, regenerative sleep that everybody needs. And we do have several studies that show lack of sleep and sleep deprivation can lead to very significant issues with your health, including cognitive dysfunction, where you're just not able to think as well as you should be able to. Also, getting up at night puts you at risk for falls. Trying to get to the bathroom without bumping into the furniture, or maybe something someone's left on the floor in the dark that you trip over. So there are downstream effects of having to rush to get to the bathroom. All right, so fecal incontinence is the uncontrolled loss of stool, whether it be liquid stool, mucus, or solid stool. Those symptoms include the urge to have a bowel movement. Sometimes it can be where you just leak fecal material and you soil your clothes due to that. There's fecal urgency, again, that sudden urge to pass stool. Fecal urgency, fecal incontinence, where you have the inability to stop that passage of stool, and then the passive fecal incontinence, where the leakage of stool occurs without any awareness or any activity. Again, these conditions can really impact your quality of life. Physical, limiting participation in physical activities because you may be embarrassed that these frequent trips to the toilet or even incontinence episodes will be noticed by the people around you. It can also make you very uncomfortable knowing that you always have to be around a bathroom. The downstream effect of that is that people find themselves very isolated, and that we know, especially in the past couple of years with the COVID pandemic, that social isolation can lead to a lot of depression. And it can also really make your world very small. So people who would normally want to travel, they find themselves putting their travel plans off because they're afraid to do so. Again, we've talked about lack of self-respect, fear of accidents, depression. Those are all psychological downstream effects of having these urinary tract or issues with your bowels. There are people that come to me, they're afraid they're going to lose control of their pelvic organs or during sexual activity, so they limit their intimacy with their partners. And of course, their partners may feel rejected, and then that makes the person who has the incontinence issues or lower urinary tract issues feel like they have in turn let their partner down. I have people who say, I asked my boss if I could sit closer to the bathroom because I have to go so often, and I'm not at my desk as often as they want me to be because I'm always having to go to the bathroom. And so that introduces a level of stress in your work environment that you just don't need. And of course, this is under domestic, but I really think that incontinence, we should have a little diagram in here in terms of how much it costs you. Depends, and incontinence devices are very expensive. Again, in the year 2000, $12 billion alone were spent on anti-incontinence devices and pads. Okay, so number one, just because you're older doesn't mean you have to live with it. I have so many people who come to me and said, oh, I just think this is a normal part of aging, so I've just been dealing with it. You don't have to do that. I have people who come to me in their 80s and their 90s who want a better quality of life, and we are able to improve their lower urinary tract symptoms. There are women who say, oh, it's just a natural part of having children or being a woman. Well, you don't, again, it's a big fallacy that somehow because you're a certain way or a certain gender or a certain age that you have to live with these conditions. Men will often be misdiagnosed where they come in, they have urinary urgency, urinary frequency, they're getting up at night, and their prostate is blamed, because oftentimes men will have an enlarged prostate that does cause symptoms. However, there are a lot of men out there who don't just have prostate symptoms, they have bladder symptoms, and the prostate's getting blamed rather than focusing on the bladder. And of course, caused by something you did. This should not be a punishment. You shouldn't say, okay, hey, listen, I did CrossFit really hard for 3 years and I've ruined my pelvic floor and this is what I get for it. So I'm not really into patient blaming, and I don't want my patients to blame themselves for their issues as well. I would like to work as a team with the patient and develop a plan so that they can have a better quality of life with appropriate treatment. I wouldn't be here tonight if there were no treatments for incontinence. So let's talk about some of the options. So this is a roadmap of care. So when you come to see a physician in the clinic and you explain your symptoms, first of all, we have to identify or diagnose the right kind of incontinence to come up with the right treatment. Now, there are several different kinds of incontinence. And this particular device or this particular treatment that I'm talking about tonight is not the cure-all for all kinds of incontinence. We're talking about a specific kind of incontinence or a specific kind of lower urinary tract symptom. So this particular treatment is for patients who have urinary frequency, urinary urgency, urgency-associated incontinence, as well as fecal urgency incontinence and fecal urgency and frequency. So first step, you want to come in and see a urologist or a physician that specializes in this. And you have an initial treatment. That initial treatment can be anything from pelvic floor physical therapy, which I'm a big believer in. It can be a trial of medications, and it can be a change in your lifestyle or behavior so that we can modify some of your behaviors so that you're not feeling the urge to go to the bathroom as frequently or as urgently. So we come up with a treatment plan, and depending on what treatment plan you choose, we go down that path. Generally, when people come in to see me, I recommend a trial of medications and a visit to the pelvic floor physical therapist, because no one can ever go wrong with more education. The more you understand about how your pelvic floor functions, the better you're going to be. You never go wrong with more education. During your trial of medications, I oftentimes will have people fill out what's called a voiding diary. So I send them home with homework. And when they come back to me, we go over that voiding diary. And that voiding diary really lets me see the degree of your symptoms and the degree of your bother. So the voiding diary consists of 3 days of you recording every time you have to go to the bathroom and your level of urge and how many times you've leaked. And that really serves as a baseline. So we take that voiding diary and we use that as your baseline, and we can follow and track your progression over the course of your treatment. It is so important to have that baseline so that we know if we're really helping your symptoms. So outside of pelvic floor physical therapy, behavioral modifications, and of course, medications, there's a procedure. And this is where I get to use some of my surgical skills to really help people. This is known as advanced therapy. Once you have done your initial therapy consultation, have your bladder diary, there are a lot of people out there who say, you know what, I had side effects to the medication, or it didn't work as well as I wanted to, or listen, I want to avoid taking this medication for the rest of my life, because if you get off that medication, your symptoms are going to return. There's, on average, a 70-year-old has 7 medications. We collect medications as we get older. And if I can get my patients off medications, then I feel like that's a win for them. With more medications, that's the more your body has to process. And a lot of medications are processed by the liver or the kidneys. So we want to protect our organs as well. So let's go over some of the advanced treatments for these kinds of symptoms. There's something called neuromodulation, which is what I really want to focus on tonight, percutaneous tibial nerve stimulation, and then chemodenervation, Botox. I can tell you a little bit about my personal bias. The percutaneous tibial nerve stimulation requires a lot of time and investment from the patient. It is where you come into the office once a week for 12 weeks to have a small needle placed in the posterior tibial nerve, and then that needle will send signals up the leg and to the sacral nerves. So that's done once a week, and then you have to have maintenance. Some people, to have the 12-week treatment and then maintenance, that's almost impossible. Trying to find a ride, trying to find time off work, and then having to maintain that through your life can be very difficult. So that's not something I personally offer in my clinic. I'm sure there are other people out there that offer that. But it's not something that I find effective for my patients. My patients want to be fixed and they don't want to spend any more time thinking about their lower urinary tract. Then there's Botox. So Botox, I'm sure you've heard of it. It has been made popular by celebrities who don't want wrinkles in their face, so they inject it into their face and then their face doesn't move and they can't make wrinkles. Well, it does the same thing in your bladder as it does to your face. So it causes your the muscles in your bladder to become a little weaker, and then the bladder is not contracting as much. And without such a strong contraction, then you're not feeling that urge to void nearly as often. Botox has to be injected on a regular schedule, so once every 6 months. I personally do that in the office. So I take a small scope, I introduce it into the bladder while you're awake. We're usually chatting during this procedure, and I inject 10 places in the bladder. I remove the scope, you go to the bathroom, and then you go home. The risk of Botox is upwards of 6% of people will be unable to empty their bladder after that treatment. So there's something called urinary retention that can result. The other problem with Botox is that people will often have that procedure done and then say, you know, I just have to sit on the toilet forever in order to empty my bladder. And then there's always a risk of urinary tract infections because we do introduce the scope and the needle into the bladder. It's a great procedure for some people and they love it, and I'm happy to do it. It's not my personal favorite. And then we get to talk about my favorite, which is sacroneuromodulation. And that's where axonics comes in. Again, sorry, I went ahead of the slide. So this is a picture of the percutaneous tibial nerve stimulation. And you can see in this graphic that someone has their foot up on a pillow. There's a little lead, the PTNS device, that's sending signals up their tibial nerve to the sacrum and then to the bladder. Again, long-term maintenance is necessary. So just going on, this is a picture of the bladder and then spots for injection. I do not do 30 injections in the bladder, 10 is enough. So all those little round circles that you see there, you don't need that many injections. Okay, and this is the meat of the topic. So sacroneuromodulation modulates the activity of the sacral nerve, restoring bladder and bowel control. So there's a lot of different ways to do this. The way we do this procedure, and this is probably in a slide later, but people come into the office, they lay down on their tummy, and then we clean their backside. And then we place 2 tiny wires into the back into the S3 foramen, and then we hook those 2 wires up to a small battery, place a piece of tape or a dressing on it, and you go home. You don't require general anesthesia. You don't even require sedation. We numb you up with some lidocaine. I guess there's some real patients there. That's great. So just to recap, axonics or sacral neuromodulation helps with overactive bladder, urinary retention, where you can't fully empty your bladder, as well as fecal incontinence or fecal urgency. Okay, so I guess we're going to take a step back and just go over how this works. So the neuromodulation restores the normal communication between the brain and the bladder by stimulating those sacral nerves. I personally call it a pacemaker for the bladder. I don't know if anybody else refers to it as that, but that's how I explain it best to my patients. And this is where they describe the procedure, where we place a tiny wire or a lead in your upper buttocks. You go home the same day. Here where it says you resume your normal activities, I don't tell my patients that, because those wires are so tiny and they're so slippery that they can migrate really quickly. So I tell my patients there's no showering, no getting a bathtub, try not to bend over, be careful with that dressing, don't take the dressing off. If you need to reinforce it, put more tape on it. Just try to keep from sliding too much, because that can also disrupt the wires. And so we really rely on those wires to stay in place for you to have a good trial. So you go home and you come back and we go over your symptom improvement. And that's where that bladder diary becomes very, very important, because I like to compare your pre-bladder diary to your trial bladder diary. And if you've had a 50% improvement in your symptoms during the trial, then you're a good candidate for the full implant. So let's go on and see what's next. Okay, so here's a couple of good pictures. So the part of the screen on the left that says Axonics R20, this is a small rechargeable device, and that little battery there that looks like a gray metal shape, that is the actual battery that we implant in the underneath the fat in the skin at the upper buttocks. And you can see the area that we place the wire into on the far left-hand side of that battery. So that's where the wire would go. And this is the battery that we use for the full implant. People will often ask, hey, am I going to feel this battery forever? It's going to be sore. Are other people going to notice it? No, it's very discreet. Other people don't notice it. And it sort of just becomes a part of your body that you don't even notice. So the battery on the left is slightly smaller because it's a rechargeable battery. The one on the right-hand side is a battery that you do not have to recharge. It's good for 10 to 20 years. I always tell my patients about 15 years. And it's also very small and thin. Most people want the Axonics non-rechargeable because it's just less maintenance. This is the remote. It's pocket size, easy to use. It's way easier than a smartphone. So anyone can use this. There's no labeling on it, so no one will know that you have issues with your lower urinary tract. This is very discreet. Now, I will say people oftentimes ask me, do I have to carry this around forever? Do I have to carry this everywhere I go? And I say no. Oftentimes you come to a setting, you use this device to control your settings, and you set it and forget it. And I tell people to put it in your jewelry box or put it in your sock drawer and forget it once you find your settings that you're comfortable with. People are concerned that because this is an implant, you may not be able to have an MRI down the road, but the implant does not need to be removed in order to have an MRI. This implant is approved for the 1.5 Tesla and the 3 Tesla full body scans. You will have to turn it off, and the rep can always walk you through that. So people really do well with this procedure. I tell people all the time, this is the least complicated most straightforward procedure that I perform as a surgeon. It has a great effective rate. So 93% of people are still happy at 2 years. And after here it's saying over 9, yeah, okay. So over 90% of people are satisfied with their result after 2 years. So that's a pretty good result. This lady looks super happy with her implant. So what are the next steps? If you have any of these symptoms and you don't want to be on medications and you want to come in and talk to me, I'm happy to talk to you about it. I'm happy to give you all the options that we presented today. But I am going to be very honest that number one, I'm biased to try and get people off medications. And I don't want people to have to feel like they come into the doctor every 6 months for a treatment. I love Botox. I think it's great for certain people, but my goal is to get you as doctor-free as possible.
And that brings us to the end of this evening's webinar. Thank you, Dr. Roberts, for your time. We hope the presentation was beneficial.
Thank you so much.